Welcome, everyone, to this most recent webinar, Insurance and Risk Management Solutions for International Transitions of Care. We're going to give it just a minute for everybody to pile in, and then we will get started. Welcome, everyone, to this webinar, Technology in Transitions of Care, the latest in a series of programs focusing on transitions of care, and specifically Project RED, Re-Engineered Discharged, and the scientifically derived and validated principles of Project RED, which can reduce the risks and costly errors from ineffective transitions of care. With Dr. Brian Jack, who created Project RED, Elizabeth Ziemba and I have developed Project RED Solutions, a consulting firm focusing on implementing Project RED in healthcare systems in the US and around the world. We're convinced that improving transitions of care results in better patient outcomes, happier staff, plus more effective and sustainable healthcare systems, and that Project RED principles measurably improve safety and care quality, increase efficiency, and reduce the risks through adhering to best-in-class standards. Project RED Solutions delivers training, implementation consulting, and measurement for better transitions of care. To learn about Project RED Solutions, access webinars, or our other resources, please visit our website, projectredsolutions.com, or contact any of us after this webinar. In our last webinar, we looked at the interface of medical insurance with transitions of care. Today, we're delighted to have John Morris, who will cover how technology, and AI in particular, is being applied in healthcare and how the Project RED standards of practice management are integrated into his futuristic scenario. It's one thing to know the principles, but it's quite another to apply them. And how do we do this? John Morris is Senior Vice President at Enira Healthcare Technologies, a company applying leading-edge technology solutions to solve problems in the global healthcare marketplace. John started his career on the payer side, focusing on cost containment for large employers, TPAs, and insurance companies. After earning an MBA at Thunderbird, he consulted for firms like Navigant and Oliver Wyman. John is in his second year at Enira Health. John is most proud of his role at the board for Host for Hospital, which is 22 years has provided housing for the patient families receiving care in Philadelphia, and collaborating with Pedro Atala Homes in Honduras. Before I turn the virtual microphone to John, I want to encourage the audience, that's you, to add your comments, questions, and observations into the chat box on your screens. Also, we'll have time at the end of the presentation for Q&A. So please cook up some good questions. John and I love a good challenge. Thank you, John. The digital stage is yours.
Thank you, Irving. I appreciate the opportunity to be here and to connect with you, the team, and our audience. as I'll walk you through just a quick sort of flow in a second. But the topic that we're dealing with, certainly transitions of care, is enormous. And overlaying technology solutions on top of that is even more enormous. And then where is AI going is, hundreds of hours of conversations. So if a topic is you'd like us to drill just a little deeper at the end, please add those questions in. Also, if I use a term or an acronym as our industry is riddled with, please let us know and we'll get that cleared up. So certainly we just wrapped up our introductions. And so we're going to look at the expanding roles of AI in the overall healthcare ecosystem. And I'll take you into some pretty specific, and not only strategic where they fit, but actual tactical deployment. And then Irving will do a review around Project Red, and then we'll have our questions and answers. And specifically, I would love to focus on how to leverage this in your own work process. So how can we get Project Red deployed for you? And then underlying that, how can we focus on solutions that help to make it more efficient, easier, lower that administrative burden associated with healthcare? So as I go through the presentation, one of the things that's fascinating is people say, if only I had the information. Well, the reality is we have the information. It's everywhere. We are awash in data in the developed countries. And then as we move out into developing world, there's an enormous amount of data available. The problem is that data is fragmented and siloed. So when we look at again, focusing just a second in the US, this first statistic always shocks me, and that is that 60% of the doctors in the United States do not have access to coordinated care data. And this is precisely what we're talking about when we talk about Project Red, right? We're talking about coordinated care data. When you think about what this means in just everyday application, that means that 6 out of 10 times that a doctor walks into an exam room, she or he do not have access to some portion of that patient's information. Only 4 times would they have access to the info. What does that lead to? Overall, it is estimated that 25 cents on every dollar spent is wasted. And that puts us at a spend of nearly $1 trillion in healthcare that is not value add, meaning it doesn't help the patient have a higher quality outcome or a better experience. 43% of a healthcare professional's time is spent either entering data or retrieving data. And I'm sure we've all heard the doctors that complain about how many clicks they have to do nowadays. What does that lead to? 21.6% churn rate for the average healthcare staff in the US. So we're seeing huge burnout right at a time that we can't afford burnout. Our baby boomers are aging, so we have a higher demand on the system, and those same baby boomers are retiring, so we have a lower supply within the system. So churn and burnout was always a challenge, but it becomes much more significant in the years ahead. The next statistic is quite fascinating. 54% of the physicians practicing in the United States don't have access to a top 10 or top tier EMR. Now, when you think in the hospital world, it's really boiled down to 3 players, and that's Epic, Cerner, and Meditech. And there are a couple of others, but in general, those are your big 3. When you look at the physician world, there are over 500 EMRs that are deployed in the US at the physician practice level. And many of those EMRs are not able to communicate with any of their peer group. So that's what's creating those data silos throughout the industry. And what does that impact mean? It means that about a $6 billion loss, or estimated, now I think this is a little high personally, but the Black Book Market Research Study said $2,000 per patient per year is lost due to the lack of interoperability within the system. Where does that then ultimately show from an outcomes perspective? So we've been talking about dollars up to this point. The US spends twice as much per capita as any other developed country. And yet we have a 28% chronic disease burden, coupled with some of the worst mother mortality rates. When we think about where we are at the very bottom, and you start looking at some of the other statistics, we aren't getting anywhere near the outcome that we would expect for that money spent. And the biggest piece of that is the ineffective transfer of information between systems. And again, McKinsey estimates that $500 to $750 billion could be saved with better utilization of data. So we think that there's probably a pretty good space for figuring out how to knock down some of these barriers. So what needs to happen so that you get to the point of insights-driven decision making? Well, first, you've got to get all of this data. And that data is sitting out there in payer claims data. It's sitting in pharmacy data. It's sitting in lab data. It's sitting in patient-reported data. It's sitting in that physician EMR that doesn't talk to the hospital EMR. It's sitting in that inpatient discharge report that doesn't get sent out effectively and communicated to the next stop on the journey. It's sitting in evidence-based clinical standards or protocols, but not sitting inside an EMR where somebody's dealing with it on a daily basis. So you then grab all those sources and you see that, so the big producers of data are payers, patients, and providers. So we as in NIRA, as an example, but anybody in this ecosystem, we have to get all of that information together. From there, we have the opportunity to leverage AI to start making real-time operational gains. Are there repetitive manual tasks within a workflow that we can automate to get that data flowing faster? I always like to use the example of a big pipe. So everybody visualize just a great big pipe like what you would see like in the big water pipes in a city. And within that, there is corrosion. And that corrosion gets that pipe smaller and smaller and smaller, and things get stuck on that pipe. And so you get down to where the pipe is only flowing this big. So when we start looking at work process, and this is, Lean Six Sigma, any of these components, if we can start scraping back some of those layers of constriction and remove some of the friction that is within the process, then the information flows more quickly. And as the information flows quickly and freely, you are able to get to some of these operational gains. We can also then start to have strategic.
If I may, John, you reference in the real-time operational gains, you reference ADT alerts. Tell us what that means.
Perfect, and that's it. That's the perfect. So that is admission, discharge, and transfer. And so as a primary care physician, I need to know when my patients get admitted to the hospital. I need to know when they get discharged. I need to know when they get transferred to another facility. And I need to know that information. So I need to be able to grab that. A lot of times in the US, that's available in some form of healthcare information exchange, but there are gaps and gaps and gaps. So in many cases, you may need to be connecting directly with the hospital and using that as an endpoint to pull in that data. Exactly, looking at Project Red, the ability to be able to pull that information electronically to then make sure that it's following the protocols and pushing to the end user quickly. That answer? Cool. Okay. I'm switching over to strategic insights. Once I know that the process is flowing and producing information, then I'm able to start looking at other components that historically have required outside consulting firms, and I apologize to my former two employers, that a lot of what consulting firms are doing is filling a gap that is a fault of the data not being able to flow. Large health systems are sometimes hiring armies of data analysts to be able to get to that same place. And at the end result, they are still not able to get to this data flowing in a consistent real-time way, which means everything is episodic or periodic, where you are then forced to make decisions in data that is older. So once we're getting this data flowing and getting this information flowing, then we can start to look at what is my ER schedule leveling? What is my, as examples, what are my staff productivity? What's my asset leverage? And am I using all my exam rooms? Am I using this piece of equipment? Could I more efficiently use this equipment? What's my network integrity? I'm supposed to be written, not IT network. I'm talking about healthcare relationship network. Am I referring to the doctors I'm supposed to refer to? Or is my front office referring to the doctor whose reps sit over some donuts last week? And so now they're referring patients over there. So as a hospital, if I have as almost all hospitals do, I have my facility, I have a series of owned practices, and then I have community-based relational practices. So I first want to go to my departments, then I want to go to my practices, and then I want to go out into the community. But those decisions are often not made effectively. And so I can now start looking at, why is this referral pattern happening the way it is? But I had to first be able to capture that data, right? The next piece is looking at quality and value-based care outcomes. So these are things like HEDIS scores. This is value-based care, VBC contract compliance. And these are often referred to as care gaps, and care gaps can have financial incentives or financial penalties attached to them. CMS is doing here in the US a lot of work around this. And so again, if I know who the patients are that need a particular type of care, then I have the opportunity to engage that patient. I have the opportunity to share that information with the provider. I have the opportunity to then notify the payer, and all the way down to, again, here we are at Project Red, the opportunity to make sure that that information is getting effectively shared with the next stop on this patient's journey, to make sure that we have that continuity of care in place. Now, how do we do this?
If I may, John, some of our non-US audience may not know about HEDIS. So if you could.
Yep. HEDIS is basically I think it's health information data exchange. I can't remember what the HEDIS stands for, but it's basically a series of information that every provider has to report into, and then they are scored based on those metrics. So this gives us the ability to track, hopefully, quality across facilities and providers. So HEDIS is absolutely important from that standpoint. Underlying all of this is what is the data science that's behind it? So we're looking at things now that are just beginning to scratch the surface. Population risk stratification. So I have a population that is in my EMR. I have a population that's in my community. I have a population that's in my MSA. I have a population based on ethnic group. I have a population based on age. We can start looking at all of these populations, and we can now say, oh, so this population that shares certain physical and maybe even behavioral diagnoses is much more likely to experience a heart attack, or much more likely to need advanced care. And we can start to target for that group. A no-show probability is one of the things we happen to do at NIRA, but other organizations do as well. And that is, we have about 25 different elements that we feed into an algorithm, and it gives a probability score back to the practice that says this patient has a 1 in 2 chance of not showing for today's appointment, 50% probability that they won't show. This other patient has a 15% probability. So which patient do I want to do same-day call out? The one that's got a higher probability they're not going to make it. Now scale that up. If I look at a patient and I see that there's an 80% probability of no-show, in that context, something else is going on. If somebody's going to miss 8 out of 10 appointments, especially if we're talking about a historically underserved community, perhaps this is transportation. Perhaps this is food scarcity. There are other social determinants of health that are driving somebody if they're missing 8 out of 10 appointments. So how does this translate across the ecosystem? Operational performance, which we talked about before. This is, think about it, running the business. So what we've seen is 50% up to 50% productivity improvements for affected staff. across job types. And we see in research trials, which we could be happy to drill into if anybody has a question on those, but we identified a 90% automation opportunity and something that took 2.5 months previously to do. The algorithm produced the first cut in 9 minutes, and within 15 minutes, we had the initial target audience out of the data that would historically the pharmaceutical company said took 2.5 months and was human intensive. When you look at quality and value-based care, think about this as the results of the business. What's really happening in delivering care? And what we've seen there is for opportunities to increase performance payments and also to increase productivity within administration of contracts. And then when we think about managing the business, that's at strategic insights. We've looked at opportunities to move margin around 15% in independent practices and moving to an 80% real-time availability of data. So think about that very first statistic that 6 out of 10 times a doctor walks into an exam room, she or he does not have the information. We can now focus on how do we get 80% of that piece in real time into the provider's hands. And then just go ahead.
So all of this is absolutely fascinating, John, as I knew it would be. And thank you. The results that you're talking about, the benefits realized so far across that bottom bar in the chart. Many of the folks in our audience, some of the folks in our audience, starting at a place where they don't have a well-developed data warehouse. They don't have a lot of data available. So how do you at Anira Health enter an environment where the data isn't necessarily as well developed, might be in, say, an academic medical center in the US or the UK? How do you tackle that data organization in to produce these kinds of benefits?
Thank you. So in a context like that, one of the things that you're seeing is US versus international. So US and Europe, the data exists somewhere. There's rarely a situation where the data simply does not exist. It's a barrier to getting to that data. And so what we're seeing across the industry is organizations that are popping up now that they are those bridges. And so they get the information flowing. Imagine for a moment we have, like the old medieval castle, right? We've got a tower and then we've got another tower. And the whole idea is if one tower falls, the other one doesn't. So everything is very rigid and protected. What's popping up in the US and, multi-billion-dollar valuations, by the way, one of my Navigant friends is at a really cool company, and they just crossed their billion-dollar valuation. And they're just building the bridges. So they're connecting all of that data to get it to flow into real time. Now, we do this in Anira on a regular basis, where we're connecting EMRs, we're connecting healthcare information exchanges, we're connecting hospital discharges, we're pulling in third-party data sets. As all of that data comes in, what many clients at the mid-market and smaller are missing a data lake. They just don't have it. They're using the store that they have in their EMR. And so if somebody has a data lake established, a data warehouse, like most larger health systems do, then we tap that warehouse because that's supposed to be pulling 100 sources and putting it into one warehouse. So we tap that. Now we've got those 100 sources, and maybe there are 5 more sources out here that we need to grab and pull in. And now we're able to consolidate that data, assimilate it, and then use that to start moving the operational gains, et cetera. What we've seen is the best run academic medical centers that we've seen, the best run hospitals in the US with really established data warehouses. There are 2 problems. Number one, they're still not getting all the data in. And number 2 is what we call insights to action, or in a more pejorative term, the so what factor, which is I've got tons of data, and I've got some really brilliant business analyst who is very proud of his Tableau report, and they're showing me a chart in, that this was always brutal in the consulting world. Then the question was, so what? What does that mean to the client? What does that mean from a tactical plan? What does that mean from a strategic plan? What's next? And so just internally, we've coined the term insights to action. So the first piece is the insight. And the second piece is, how do I automate the action from that? And I'll give you just a tiny little example. So an insurance company says that these 1,000 patients are attributed to a healthcare practice. That's nice, right? What happens? You have to then reconcile that attribution against an electronic medical record. So in the old days, somebody manually got the list and went and checked it off against files. In the more automated piece, somebody gets the list and then in Excel, spend some time to find the net new patients in that attribution list. What we focus on is automating that. Drop the attribution list in, reconcile it to the EMR, quick reg the patients into the EMR, fast feed an outreach program, drop the data into the chart prep, and then after the patient's seen, close the gap with the insurance carrier. So we're looking at, okay, the insight is interesting, but the insight then drives the next step on that process, which impacts the patient's journey through the process. And I think this is where, as an industry, it's going to get really exciting. Yeah. And then just back to talking about here, now this is a plug for us in Naira Innovation Incubator, but every company out there has to be doing some level of innovation. In our case, we take every business case that a customer presents to us, and every idea, and we turn it into a business case, and then we stack rank it against our priorities and the opportunity. And we then look at that and say, should this go to I3? And in I3, then we develop an initial engineering spec, and then we develop a initial proof of concept, and then we engage with a beta site, and then we test that. So these are some of the things that are interesting. Our experience has been, in our case, 43 discrete solutions that we've developed that didn't exist in the market or didn't exist in an effective way. And then 6 big strategic opportunities that we've identified. I would expect that every organization that is tech-based or tech-dependent has to be focusing on this. Our market is moving faster than I've ever seen, and let's just say when I started the career, I had hair, so it's been a while, right? But we are at an accelerated pace, and the externalities that I mentioned earlier, where demand on the system is increasing exponentially and supply is decreasing substantively. When you have that sort of inflection point in any market, whether this were manufacturing cars or making buggy whips and before the cars happen, when you have an explosive demand and you have a constricting supply, it forces an ecosystem to come up with better solutions. And we simply can't meet the needs of the market if such a substantive portion is retiring right at the time that we have the highest spike in demand that we've had.
One of the things that one of the metaphors I've heard used about artificial intelligence and machine learning within healthcare, John, has been this concept of the introduction of electricity. When electricity was introduced, manufacturers were slow to adapt to the use of electricity because everything was built around steam power.
Yeah.
And that the introduction, that electricity actually came to drive the decisions and the major capital investments in many, many industries. How in your point of view, how is AI and machine learning changing the dynamic? Many of us understand about EMRs and the deployment of electronic medical records within healthcare, and the intention of that deployment is to improve efficiency, increase accessibility, improve the ability of patients themselves, the consumers, to access their own information. How is AI and machine learning turning this model around?
So the thing that's interesting is AI is an intensely ill-defined term. AI is whatever people want to call it, right? And so when we really start looking at some of these solutions that are out there, we start thinking about where do they fit. And I think my crystal ball and just as a reality check, the real estate market in the U.S. collapsed in 2008, and I bought properties in '06 and '07. So don't trust my crystal ball. so, um, but I do believe the sort of nirvana future state is where we can look at a patient and we can know what's going to happen to that patient far in advance and be able to intervene in a way that extends substantively both quantity and quality of life. And that's the really cool stuff. Can we get genetically coded medication and based on some particular genome study, can we make sure that we are altering a component of a living environment or a food or those things? That gets really interesting. This is horrifically complicated, and it requires you, and that's real. When you start getting out there, that's real AI, right? I mean, where we're starting to change fundamentally how we treat patients, and hopefully exponential changes in outcomes. Between here and there, which is where we live as Inira and most other companies that we're seeing, and there is a Wild West rush in right now. What's driving that rush is the externality that I talked about earlier: demand, increased supply, static or decreasing substantively. And number two, we're somewhat the last frontier. Fintech, banking has already had a lot of our AI, got there sooner. You start looking at supply chain work, you start looking at sales and marketing, and they've all had stuff sooner than what healthcare is getting. So healthcare has been a slower adapter, which means people can come in and leapfrog with nearly fully developed solutions that would have taken and did take months/years in another sector to be able to get to. So healthcare's got this really intense demand for it and the ability to transfer a lot of this knowledge in. I can't tell you the number of emails I get on a daily basis of organizations that are entering the market. So there's just this is going to be incredible. What I see us able to accomplish in the next 3 to 5 years is poorly designed or inefficient work processes that presuppose a human to human interaction that is not clinical. I think those are going away. If it's clinical, where a doctor or a nurse or a physician assistant is in a room talking to a patient and doing what AI can't yet do, which is really ascertain the next logical evolution for that patient. That stuff's got to happen. But when it is, Sally Sue's my generic human. I use her for every job because I don't ever want to call out anybody else's name. So it's Sally Sue. Sally Sue's role of taking data manually from report A and cutting and pasting that data into report B, that is going, I believe, across our industry, is going to vanish, as it's going to be that inflection point that happened with the buggy whip manufacturer when cars finally caught on. It's going to be the gas fixture seller when electricity replaced gas in the house. It's going to be that steam boiler manufacture when fuel tanks replace the need or coal bins replace the needs. That piece of taking an inefficient process and compensating for that inefficiency by a low value add human input, not anything negative about that human. I think they can be in a much higher practice at the top of their license. I genuinely think that you're going to see revolutionary change in the next 3 to 5 years in that space. Yeah, we've got a relationship right now that expects to refer between 400 and 800 clients to us in the next year. That sort of, and clients being counted as substantive practices. I never saw that earlier, except when some government reg changed, and then the market had to change to that government reg. We're at that place. Let me just real quick show one outcome and then get this over to you for Project Red. So this is just a case study. I use this one for today's presentation because they're an amazing organization. I have so much respect for COPA, and they are treating a very, very difficult population, not as human beings, but as complexity of care. And so they treat the severely mentally ill, and they're the largest provider in Maricopa County. And so they had some challenges where their data was scattered, leading to absence of care alerts. So they were finding that patients needed these alerts, but they weren't getting the data. And then they were finding that there were some challenges around personalized care because people couldn't get to it because they were focused on getting the data as opposed to interacting with the patient. And they couldn't maximize then the incentives associated with having access to that data. This is a longstanding client of ours. So what we did is we created a predictive risk stratification model. So based on AI and machine learning, and this was about insights. So we put in their comorbidities and the severity. We put in the patient demographic and then the social determinants of health, like marital status, gender, ethnicity, medication, substance abuse. We put in the no-show probability index. This particular one has 15 parameters because of the nature of the population. Our generic one that goes out for group health is 25. And then from that, we gained an understanding of how the population is affected by all of these different factors based on k-means and Elixhauser models. The result was a 50% productivity gain for select staff. So they had better health outcomes and higher clinical satisfaction. And then we were able to define risk faster and with far greater accuracy than traditional. And that led to significant increase in incentives, also producing a scorecard so we could see how the particular providers were doing for the particular patients. So this is just an example of that sort of meaty work that is happening every day across the industry, across the sector. And we will move organizationally, I think, and market towards some of those more aspirational goals. But this stuff's already happening. This is already being done. Okay. Thank you so much. I'll hand it back over to you, Irving, for the transitions of care checklist and the principles of Project Red.
Thanks, John. Terrific. Everything you've presented here, everything you've presented so far could be the subject of another webinar. I'm fascinated by it, and I have questions, so I hope the audience does as well. What we're focused on at Project Red Solutions are the glitches that occur in transitions of care. And when we look at the movement of an individual from one place to another place, or from one level of care to another care, what John was talking about, the intensity or the frequency of these situations in the healthcare ecosystem, they are indeed significant. And they're not especially on the international stage, these transitions are not being well looked after. So what we're trying to do is we're trying to improve the discharge process or the transition process, reduce hospital readmissions, which are a significant waste of resources and put patients and providers at risk, and thereby improve the patient outcomes. So these re-engineered discharge practice standards boil down to 13 elements. And these elements break down into two domains. One is the systems or the systems environment, and the other is the interpersonal or behavioral environment. And the first of these, and John alluded to this in his presentation about how artificial intelligence manages information and data, the first of these is to provide a written after hospital care plan for the patient that the patient can understand. It seems so logical, so self-evident, but so often does not occur. By the way, you don't have to write all this stuff down. You can access this full list at our website. The second, and equally critical, is a medication reconciliation and educational function. So often patients have medicines before they get into the hospital, have different medicines in the hospital, and then when they go home, they're totally confused about which medicines they should be taking, when they should be taking. They go back to taking their old medications, or when the hospital medications run out, they start taking their old medications again. Up to 40, at least 40% of hospital readmissions, unnecessary hospital readmissions, are probably due to medication errors. And if those of you who are interested in this particular aspect of this informational glitch in transitions of care, I would refer you back to an excellent webinar given by Stephanie Sabicki, a pharmacist for Project Red. It's on our website. The next is to create a follow-up plan for outstanding labs and tests. If an individual is sick enough to be in the hospital, he or she is sick enough to require care after the hospital, and therefore labs and tests are part of that. And there's very often very little connection, very little follow-up in that regard. So things fall through the cracks. The next is to arrange for follow-up appointments that the patient keeps. This means that the hospital or the clinic that's caring for the individual needs to make sure that the follow-on appointments are scheduled in a way that the individual can get there, can make the appointments. Doesn't contribute any value or do any good to schedule an appointment for a patient on a Friday if the patient doesn't have access to transportation on a Friday. So that the critical ingredient here is arrange follow-up appointments that the patient can actually keep. It's incumbent to organize all the post-operative or the post-discharge services and equipment. If the patient needs oxygen, if the patient needs a bed, if the patient needs a wheelchair, a walker, a cane, whatever the patient needs, supplies, making arrangements at the time of transition to be sure that the consumer, that the patient has those things. If there are standards of care where you are, national, local, regional standards of care having to do with equipment or medications, or having to do with frequency or follow-up, making sure that those are reconciled and adhered to as well. John actually referred to this in his presentation. It's a standard of care that the follow-up care be sent, that the information about the discharge, the summary, the after hospital care plan be sent to the consumer or patient's primary care provider within 48 hours of discharge. That's a standard of care. And the research shows that this is being done maybe 3 out of 10, maybe 4 out of 10 times. Also provide meaningful telephone reinforcement within 48 hours after discharge. Somebody calls the patient. How are you doing? How does the wound look? How are you feeling? What about the medications? And to interview the patient constructively about these issues within 48 hours. Those are the systems-based standards. On an interpersonal level, it's critical to assess before the patient leaves the institution where the care is provided. It's critical to assess the patient's understanding of uh, discharge diagnosis, of discharge care plan, to determine what they know, what they understand, and what they don't understand. And this is often called teach back. So to provide information, pause, and then ask the patient, what did I just say? So which medicines do you take in the morning and which ones do you take in the evening? Determine that allows you to determine the need for language assistance, provide education about the diagnosis, and involve the family caregiver in this transitions of care planning, and explain common problems to the consumer, to the patient, and to the family caregiver, and what to do if problems arise. It doesn't work to say to the patient, well, if your wound becomes inflamed, you have to explain to the patient what it means to have an inflamed wound and show the patient what it means, actually with pictures. So all of these standards can be secured, can be found in the Project Red Solutions website. These standards of care are the new practice standards for transitions of care in both domestic and international environments. So, in principle, why focus on transitions of care? Because, as I said, and this is actually a quote from Dr. Jack, who designed Project Red, if you're sick enough to be hospitalized, you're going to need care afterward. Hospital readmissions can be the result of a clinical change or incomplete initial treatment or even poor quality treatment, or they may be based on poor or inadequate patient engagement, systems procedural errors, or unnecessary readmissions. They absolutely put the patient at risk and the provider at risk, and they waste critical resources. The evidence is clear about unnecessary hospital readmissions and poor transitions of care at discharge. There's a very low percentage of the population that actually has their discharge information available to them. And very often that discharge summary, that transitions of care information, doesn't have information about the hospital course, doesn't have information critically about discharge medications, but doesn't include completed test results, pending test results, and follow-up plans. There's a lot that's missing that needs to get resolved. One of the hopes for artificial intelligence and machine learning for this new environment is to incorporate these things and to just like a form that you need to fill out that you can't get past a certain field unless you fill it out, there should be a requirement that these things are done before the individual is allowed to be moved on to the next point of care. The point is that direct communications with after hospital providers is miserable. It doesn't occur, it occurs poorly, and in the international space, in the cross-border space, it's extremely fraught. It doesn't appear to be considered as necessary for discharging providers. A provider in Spain that's discharging a consumer to England, is it his or her responsibility to communicate with the PCP, the primary care provider that the patient has in England? We would say that it is indeed a standard of practice in those environments. So I want to stop there, and if there are questions, you can reach John and I at this contact details, and would welcome the chance to talk with you further about any of these subjects. Do we have questions from the crew, from the audience? Emily?
Sure. The first one is, how do the Project Red standards differ from current practice?
John, you want to? Well, I'll start. These standards of the Project Red standards should be the standard of care for all transitions. I can't be sure how they might differ from the standards of care in the environment of the person asking the question, but I can tell you that probably 3 to 5, 30% to 50% of the time, all the standards of care are not being adhered to. And of course, the underlying standard of care is communications, whether that communications is person to person or data to data, those standards are not being adhered to. John, what's your experience in this regard?
So I think there are two, it's so the common sense standards that you shared, Irving, I think every organization agrees with them. And these are logical, pieces that make sense. Have the organizations then integrated that into their process, even intra-system, meaning that the hospital itself, the organization itself, have they integrated that? I would argue, at least for my consulting background, is no. They're not all integrated from the hospital systems that I saw. And then secondly, think about for a moment, let's just use the ADT alert 2 days for PCP to pick up from a discharged patient, right? So let's assume for a moment that Sally Sue gets discharged from the hospital. How do we get the information in that discharge plan over to the primary care physician? Remember that there are over 500 EMRs in the United States, and less than half of them are on a top 10 EMR. But also remember the inverse of that. The hospital side is concentrated. So the hospital is almost always producing that information from Epic or Cerner. Those are some of the least communicative EMRs out into the physician world. So I've now got to get this data that somebody has, get it out of an Epic universe in this context that I'm giving, and get it out into a next gen EMR, which is the name of one of them, or eClinicalWorks, or Athena, or Practice Fusion, or Dr. Chrono, which is one that's out. And these are just some of the Care Tracker. These are just some that we've been dealing with in the past couple of months. So I've now got to take that data and get it into that EMR. Then I've got to get that information within the EMR to a place where the doctor sees it.
Right.
In a way that it's summarized. This isn't just about getting a PDF attached as a document. This is about taking that important information and getting it into the chart in a way that is consumable by a physician or an MA or a PA that's in the room for 8 minutes with that patient. So now so I've got that into the EMR, I've got to get it up in front of them. So these are some of the things that I'm seeing that we're seeing as an industry are sort of knocking down some of those barriers. But man, there were a lot of those barriers. And so I would say that you have a two-tier challenge. Number one, intra-system adopting the principles and making sure that they're integrated into process. And then number two is working as our whole industry, our whole ecosystem, in being able to get that information from point A to point B. Point A is a hospital discharge. Point B is a physician in the office with a patient or on a telehealth visit, checking the meds, having the discussions, and determining the next steps. And that there's a lot of work to be done in between there.
Yes, and that's where I think that's an excellent summary of the major silo obstacles to interoperability. Without having everybody's eyeballs glaze over, the major EMR systems in the United States have had significant interoperability obstacles,
Mhm.
even though legislation in the form of regulation exists that require these operating systems to be fully interoperable. They are anything but.
Yep.
And that fragmentation, you pointed out, that was, I think, the lead slide from your deck, John, is that there's data everywhere. It's just not available, which is why we believe that systematically implementing standards of care from Project Red, that have been demonstrated to reduce inappropriate or unnecessary hospital readmissions by up to 20%. So 1 out of 5, it's possible to reduce those. That's the easy pickings, so to speak, of implementing standards of care. Now, in a hypothetical, futuristic, artificial intelligence environment, we could create things like modeling that would allow the discharged hospital or the primary care provider to anticipate who's going to be
Mhm.
likely to be readmitted, and therefore, wrap that person in cotton wool before he or she leaves the hospital. I have an observation here in the chat that I think is quite apropos. Just as an observation, in the international cross-border situation, this is a care manager from England whom I know. Hello, Zahid. The discharge documentation is often lost in transition or translation.
Mhm.
And he observes, here is where AI can help immediately. Well, if the discharge information can be transitioned into an environment that's accessible and easily, AI does a wonderful job translating, but if the consumer can grab his or her information in a relatable way, then perhaps there's an opportunity for that information to be actually used in her follow-on care. Is that realistic, or am I dreaming here, John?
Well, I think it's absolutely correct, and you touched on this in the standards. Um, you know, providing somebody who either is a non-English speaker or that English is their second language, and providing them with discharge documentation that's in English and covers, I don't know, and I think I'm decently intelligent. I'm not sure what the real definition of an inflamed wound is. And I'm a native English speaker who works in healthcare. I mean, I can guess that it's probably meaning it's red and maybe there's a little swelling, but I would bet there's nuances to what inflamed means to a nurse or a doctor and what inflamed means to a consumer of that information. And
Right.
so, and then overlay that as English as a second language or non-English speaker. Of course, there's opportunities for us to get it into the language of the listener.
Yes, and that's one of the reasons I believe that in the transition process, it's extremely useful to show the consumer and his or her caregiver, to show them pictures of what this is supposed to look like
Mhm,
or
mhm.
not supposed to look like, in addition to attempting to describe what it feels like, or to the individual, or what it should feel like if you touch it.
Yeah.
Should it feel this way or that way? Well, we have once again uh, accessed our audience for a full hour, and I want to thank you, John, for an excellent presentation, and thank you to everyone for attending. Look for an email from us, from Project Red Solutions, with the link to the recording of this program, as well as a brief survey, which is very helpful to us to help design future programs. We encourage you to share all of the resources on the Project Red Solutions website with your colleagues and others whom you think may benefit. Be on the lookout for more programs where we'll expand on the topic of care transitions in the international stage, examining how transitions of care are handled in other countries and between countries. Be on the lookout for these emails. We hope they don't just wind up in your spam. And please visit Project Red Solutions to access today's program and our other resources, and to learn more about how Project Red Solutions can help you take advantage of Project Red principles and can help improve your transitions of care. Thank you, and have a terrific rest of your day.
Awesome. Thank you, everyone. Take care.